Next presenters then are McMaster University, Don Bowdish. As you've seen, if you could introduce yourself for Hansard, you have up to 10 minutes to present, and then we go to questions from the caucuses.
Wonderful. Thank you. Thank you, Chair, Vice Chair, committee members, and Clerk, for providing me the time to give this deputation on the matter of Bill 41, the Lung Health Act. My name is Dr. Don Bowdish. I'm the Canada Research Chair in Aging Immunity, and I'm an Associate Professor at McMaster University. So as your Canada Research Chair in Aging and Immunity, I want to point out why Bill 41 is of particular importance to an age group who I care deeply about, older adults. As I'm sure that you're aware, the percentage of those that are over 65 in our province is at the highest it's ever been, and that number will continue to rise. Personally, I don't think of this as a negative. Older adults contribute more volunteer hours, they contribute more unpaid caregiving than any other demographic, and I personally value their contributions to our community and our province. However, I do often hear them blamed for increasing healthcare costs. I'd like to point out that aging a good hot health costs very little. Not needing to go to a doctor when you're 70 costs just as much as not needing to go to a doctor when you're 20. However, chronic disease, aging with chronic diseases and lung diseases are a major component of those chronic diseases. Those are what complicate care and drive up healthcare costs. I'd like to give you some examples of how having a Lung Health Act and a dedicated Lung Health Action Plan would improve the lives of older adults and those of us who care for them. So, as you've already heard, the leading cause of hospitalization in older adults is chronic obstructive pulmonary disease. So we have ample data demonstrating that community-based care by respiratory therapists or respiratory health personnel, tailored apps that patients can use on their phones, and self-management strategies that can be taught to both the patients but also their caregivers reduce the frequency of emergency room visits. And yet, so many of our older adults receive their primary care in the emergency room. This is not a sustainable strategy, and it's not something any of us want for the older adults in our lives. Ontario needs Bill 41 in order to implement quality, evidence-based, community-based care that will decrease these hospital visits. Another example I'd like to give you is that of lung cancer. Lung cancer kills more Ontarians every year than prostate cancer, breast cancer, and colon cancer combined. Yet, the percentage of research dollars specifically dedicated to lung cancer as opposed to all the other cancers is optimistically estimated at less than 5%. Lung health advocates consistently rank reducing the stigma of lung disease as an important component in lung health. The perception that lung cancer or other chronic lung conditions like pulmonary fibrosis or COPD are a smoker's disease or somehow the patient's fault means that there are fewer donations that go to nonprofit organizations that do patient advocacy or patient care. There are fewer advocacy groups that lobby our major funding agencies, and as a consequence, there's less research dollars specifically dedicated to lung cancer and other lung diseases. So this means that not only is there less research, but then there are fewer training opportunities for our young people, our young scientists and clinicians, and when at the end of the day, this ends up meaning less capacity and contributes to these unacceptable mortality rates. Let me assure you, there's no scientific reason why lung cancer should be so fatal. It's merely a training, research, and opportunity-based mortality. Eliminating stigma through community-led education initiatives will affect more than just the patient, but it will change the research and clinical care landscape. Ontario needs Bill 41 in order to increase education, awareness, and patient advocacy. Another example, and one that is certainly dear to me as I study aging, is that the foundations of lung health are truly laid down in youth. Asthmatics who don't actively manage their asthma when they're young become very challenging to treat as they grow older because their medications are now less effective. My respirologist colleagues find that caring for older asthmatics who have comorbidities, like we've heard about, cardiovascular disease, depression, obesity, are particularly challenging because we don't understand how those diseases work together to complicate asthma, and we don't understand how the medications work together to complicate or reduce the efficacy. So one important investment in lung health in old age is never smoking or smoking cessation. Smoking cessation at any age will improve complications down the road. However, the earlier you begin smoking cessation, the greater the impact is going to be. A recent study has demonstrated that smoking cessation programs that begin during unrelated hospital stays are particularly effective. Others have found that strategies that are tailored to specific groups, like youth or Aboriginal populations, and are delivered by those same members of those same groups, are also particularly effective. Many studies have shown that community-based respiratory health professionals are more effective and less expensive avenues for helping patients manage their asthma. If we had a Lung Health Advisory Council that could draw on the expertise of the greater than 40 members of the Ontario Lung Health Alliance, we would get good advice on the best practices to prevent costs now and in the future. Ontario needs Bill 41 to draw on the expertise of stakeholders, from patients to professionals, to implement the most effective strategies in patient care. My own research is on respiratory infections such as pneumonia in older adults. You're probably not aware that getting pneumonia in mid to late life can actually accelerate or exacerbate other seemingly unrelated conditions, especially dementia and cardiovascular disease. In fact, physicians often think of pneumonia as the slippery slope that's the beginning of the loss of dependence and reduced quality of life. Diagnosing respiratory infections like pneumonia is particularly challenging with people who have pre-existing lung disease or other comorbidities, and this contributes to antibiotic misuse and antibiotic resistance. Preventing lung infections by better vaccination programs, better diagnosis, will provide more years of healthy, independent living, and this is completely consistent with Ontario's Action Plan for Seniors. Although I can, if pressed or if writing a grant, provide you with ample statistics about the economic benefit of preventing lung infections in older adults, my guess is this is something that we, because we are not burdened with anyone who's too young at this table, are collectively and intuitively aware of. We all know the challenges of dealing with the older adults in our lives. Many baby boomers are unpaid caregivers. They're caring both for their parents who are in their twilight years, but also their grandchildren. And this unpaid care is a major contribution to Ontario families and our province's economy. Keeping the over 50 crowd healthy, which is my mandate, with a directed lung health action plan will mean that many Ontario families, including my own, can breathe a little easier. I'd like to bring up one more point for you to consider. Ontario is a major research hub for lung research, despite the fact that this is a chronically underfunded disease. Our university hospitals in Toronto, Ottawa, London, and of course Hamilton, where I'm from, have actually led the world in the treatment of asthma, diagnosis of rare diseases, and creating evidence-based practices for improving clinical care. In fact, there are a number of very exciting new initiatives at our university hospitals that have the potential to make Ontario the premier centre for clinical trials in lung health. As you know, healthcare is a major economic growth industry. The creation of a lung health action plan and coordinated directed research that brings together the incredible intellectual resources we already have in this province would put us on the map as the best place to do research and help us retain the highly skilled young scientists, clinicians, and healthcare workers who we invest so much in. Ontario needs Bill 41 to make Ontario the world leader in respiratory health and respiratory care. So as the Canada Research Chair, as your Canada Research Chair in Aging Immunity, as a researcher, a scientist, and someone who has older adults in my life who I care deeply for, I'm in full support of Bill 41. I look forward to having a plan on the table that addresses some of the cracks that older adults fall through. And I look forward to continuing to work with the Ontario Lung Health Alliance and dedicated politicians and stakeholders to improve the lives of Ontarians today and tomorrow. Thank you very much for your time and your consideration.
Thank you very much. And we go first to the government. Mr. Dillon.
Thank you very much. Thank you, Ms. Bowdish, for your presentation to the committee this afternoon. We know people are living much longer and therefore they'll need more health care. And people who are using our healthcare system the most have chronic conditions. Can you explain how research and immunology can help the top users of our healthcare system, and how we can keep people out of the hospitals?
Absolutely. So as someone who studies infectious disease, I have a strong mandate to keep people out of the hospitals. That's one of the best things we can do to reduce infectious disease in older adults. Aging in good health costs as little as being young and in good health, but it is in fact chronic diseases. And what tends to happen, and we've heard from Dr. Gershwin, is these chronic diseases tend to travel in pairs. You don't just get asthma, you get asthma and depression. You don't just get COPD, you get COPD and heart disease. And it's those users who have an unfortunate number of these comorbidities that tend to be the most challenging to deal with, because again, we don't understand medication interactions, we don't understand how they compound each other. So there's a few things we need to do. Prevention, and there are simple preventative strategies that we can use. Management, so people who are taught to manage their asthma, their COPD, stay out of hospital for longer. They have fewer of these complications. But there is a certain degree of research. We seem to see that there are some individuals who, despite best efforts, seem to be on a poor aging trajectory. Some of the research that's coming out of my lab and others have shown that we may be able to intervene once we identify those people. And that's a long-term research goal, to keep older adults healthier for longer. What we all want for all the older adults in our life is a long, healthy life and very little time living unwell.
Thank you. Thank you for your answer. Can you explain briefly how pathogenic microorganisms affect us so much, especially when we're talking about our lungs?
Yes, well, one of the things that people are often most surprised at is one of the major things you can do to keep yourself healthy is stay away from small children as an older adult, and yet one of the best things you can do for your cognition and keeping is to be involved in your grandchildren's lives. So one of the things that's actually people don't understand is having good vaccination programs for children for influenza and pneumonia is actually more efficacious sometimes than vaccinating the older adults. So having targeted vaccination strategies for children and healthcare workers and those who care for older adults is oftentimes more efficacious than vaccinating the older adults themselves. So these are the sort of coordinated, thoughtful, intelligent, evidence-based strategies that we need to rely on our respiratory health alliances to develop for us.
Thank you. Thank you very much for your answers.
Okay, thank you. We go to the official opposition. Ms. Marto?
Thank you very much for coming in. I wanted to address a couple of the things you said. One is my mother, who never could light a match, my late mother, never did light a match, never lived or worked with anybody who smoked, but she died of lung cancer. Mm-hmm. And I think that people have a hard time understanding that. And I think that a lot of times people, in fact, don't believe me when I tell them that. Mm-hmm. And I think that we definitely need a lot more public awareness in that regard. So I'm fairly certain that you'll agree with me on that.
Absolutely.
In terms of vaccinations, and I'm so glad that the member opposite got you to bring that up, because I think that it's a real challenge for us as members of provincial parliament when people come to us to notarize those forms saying that they don't want to vaccinate their children. And there are some of my colleagues who refuse to notarize those forms, even though it doesn't mean you're agreeing with them, but they just don't want to be a party to that. Then there's colleagues who just sign it and don't discuss it. And my compromise has been to spend 10 minutes. I'll sign it for you. You don't have to pay a lawyer, but you need to give me 10 minutes. And part of that 10 minutes is that there are people who are elderly and immunocompromised, individuals who are ill or elderly as well. There are people who can't be vaccinated, children for all kinds of challenging reasons can't be vaccinated, and you're not vaccinating your child just to protect your child. It is a community that we live in together, and sometimes we do things to protect other people. And I think that that's a big, big challenge for healthcare providers, to educate people. And we're hearing, BC this week, that there's been a rash, an outbreak of mumps. So what would you advise in terms of the task force having people on there who have expertise in these kind of challenges? Like what would you sort of see?
There's actually a very interesting literature on how to approach people who are anti-vaccine. So one of the first things you ask is, what are your particular concerns, and not making assumptions about what their concerns are. Yeah. And I agree with you completely that sometimes the most evocative argument is you're not doing it for yourself, you're not even doing it for your children. You're doing it for someone who's on cancer therapy and has essentially no immune system. My own children were forbidden to see their uncle when he was on cancer immunotherapy because it's known that they carry infectious disease that he would have been particularly prone to. You're doing it to protect the older adults in your life. You're doing it to protect those who don't. So I think having that conversation is one that tends to be particularly evocative. And then having, really skilled healthcare providers who can answer whatever the particular concerns are that's stopping it. For example, one of the examples I always give is I've been in many a research study, and I have had influenza in many years where I wasn't obviously sick. So even though I wasn't sick, I was still transmitting, and that's an important argument that people need to know.
And I'm sorry to say with that, you're out of time. We go to Madame Jalina.
I loved your presentation. Thank you so much for coming. Putting a lens on older adult, I think, was something very worthwhile this afternoon. You did say something that piqued my interest to no end here, that there is no reason for lung cancer to be so deadly. Could you repeat that and explain it to me?
Yeah, so one of the reasons we have a hard time diagnosing lung cancer is we don't have pain receptors in our lungs. So you can have a huge tumor and you won't feel it. So that is a major issue. So diagnosis is absolutely an issue. Having said that, though, the lung is actually a fairly easy place to access. We should be able to, if we inject a therapeutic, it goes to the lung first. We should be able to do surgery in the lungs. So many of the novel immunotherapeutics that are in trials at my own university at McMaster and other places are actually predicted to be particularly efficacious in lung cancer. However, they can't find the research dollars to actually get a cohort of lung cancer patients and put them. So scientifically, lung cancer in some ways, one would predict it would be less challenging than breast cancer, colon cancer, or prostate cancer. And yet, without the research dollars just to try some of these therapeutics or target them, those trials aren't happening. And so I would predict that if we had a concerted research focus to really tackle this, I bet we would make pretty spectacular progress pretty quickly.
I get it. Okay. My second one is that you went on to say that people with COPD often receive their primary care in the emergency room because education in the community and a whole bunch does not happen. I take it that you brought this forward because you are hopeful that once we have the Lung Health Advisory Council, things will change for the better, and I agree with you, it has to change for the better. How did we get there? Why is it that we don't do this already?
In my city, Hamilton, we have major economic disparities, and it's been shown again and again that people of higher socioeconomic status will access health care in a way that people of lower socioeconomic status won't. And so unfortunately, especially for people who have complicated care, maybe don't have a good primary physician, maybe have got a diagnosis, maybe they haven't, they go to the emergency room again and again and again. And without good follow-through and without good community care, they come back to the emergency room. You know, getting educators into the community has been shown again and again to be an efficacious way of especially dealing with people who have challenges to accessing health care. And unfortunately, socioeconomic status is one of those challenges. So I am extremely hopeful that increasing community-based care, respiratory therapists will help, especially those who are the most vulnerable.